The goal is that after this presentation, you will be able to accurately define and label thoracic lymph nodes to conform to the new lymph node map, recognize the differences between the new proposed lymph node map and the old lymph node map, and recognize size criteria and pitfalls associated with each lymph node station. Before we begin, I would like to ask you to take a quick sec and ask yourself, to which lymph node station does this lymph node belong to? Thoracic lymph node maps have been used to describe the clinical and pathological extent of lymph node metastasis in lung cancer patients by labeling regions of intrathoracic nodes using a system of anatomic descriptors and numerical levels. Having precise, universally accepted nomenclature to describe lymph node involvement is key to assessing treatment outcomes, comparison of results, design of clinical trials, and selection of therapy. In the 1960s, Naruki and coworkers developed the first lymph node map, which was first widely used and accepted in North America, Europe, and Japan. In the 1980s, two notable lymph node maps were in play in North America. The first lymph node map was an adaptation of the Naruki lymph node map and was advocated by the American Thoracic Society and the North American Lung Cancer Study Group. And the second lymph node map being used in North America was actually the Naruki lymph node map, and this was advocated by the American Joint Committee of Cancer. In the 1990s, Mount Dressler modification of the American Thoracic Society map was developed, and this was widely used in North America, sporadically used in Europe, and not used in Japan. So basically, in the end of the 1990s and the first part of this century, we had two lymph node maps in play: the Naruki lymph node map and the Mount Dressler modification of the ATS map. However, important differences in the descriptors of mediastinal lymph nodes existed between the Naruki and the MD-ATS lymph node maps. The most significant discrepancy was that level 7 subcarinal lymph nodes in the MD-ATS lymph node map corresponded to levels 7 and levels 10 in the Naruki lymph node map. As a result, some tumors staged N2, stage 3A according to the MD-ATS lymph node map, were staged as N1, stage 2 by the Naruki lymph node map. To reconcile the differences between the Naruki and the MD-ATS lymph node maps, the International Association for the Study of Lung Cancer developed a revised lymph node map. Notable changes included the following: anatomically distinct descriptors provided for all lymph node stations, with the upper and lower anatomic borders described in particular detail. The boundary between right and left-sided level 2 and level 4 lymph nodes is set to the left lateral wall of the trachea due to lymphatic drainage patterns. And 3, supraclavicular and sternonotch lymph nodes, which are not previously considered to constitute a lymph node station, are now characterized as level 1 lymph nodes. And lastly, certain lymph node stations are grouped into zones for future prognostic analysis and do not represent a current standard nomenclature. After that quick historical lesson, I expect to have possibly lost your attention. I usually lose the attention of my residents. So let's take a next couple of slides to emphasize why correct labeling of thoracic lymph nodes is important in our daily practice. Incorrect labeling of a thoracic lymph node can lead to a change in end distinction. And most importantly, for example, N1 versus N2. A change in end distinction can change stage and therefore influences prognosis relayed to the patient and treatment options offered to the patient. Lymph node sampling is often required for staging. So the location of the lymph node influences the type of invasive surgical procedure chosen. Incorrect labeling of thoracic lymph nodes can theoretically lead to incorrect invasive surgical procedure chosen or confusion at first, and therefore incorrect lymph node sampled. For the next few slides, I'll go over each of the 14 lymph stations in the new lymph node map. For each station, I will focus on the anatomic landmarks distinguishing each lymph node station from the other, with the upper and lower anatomic borders described in particular detail. For each station, I have provided color-coded CT maps to help reinforce the definitions. The first lymph node station we will discuss are the station 1 lymph nodes. This is a new lymph node station, also known as the lower cervical, supraclavicular, and sternal notch lymph nodes. Station 1 lymph nodes are further subdivided into 1R and 1L. 1R refers to right-sided station 1 lymph nodes. 1L refers to left-sided station 1 lymph nodes, with right versus left distinction set to the midline of the trachea. The upper border of these lymph nodes is now set to the cricoid cartilage, whereas the lower border is set to the clavicles bilaterally, and in the midline, the manubrium. These color-coded CT images help reinforce station 1 lymph nodes. As mentioned before, we are at the level of the cricoid cartilage, and the image on the bottom left is above the level of the manubrium. So these would be considered station 1 lymph nodes, with right and left, again, separated by the midline of the trachea. The next lymph node station I will discuss are station 2 lymph nodes, upper paratracheal lymph nodes. Again, further subdivided into 2R and 2L, with 2R being the right-sided upper paratracheal lymph nodes, and 2L also are known as the left upper paratracheal lymph nodes. However, right versus left distinction is now set to the lateral border of the trachea. The upper border for station 2R, the right upper paratracheal lymph nodes, is set to the apex of the right lung and pleural space and the manubrium in the midline. The lower border for station 2R is set to the intersection of the caudal margin of the left innominate vein with the trachea. Whereas for station 2L, the upper border is also considered the apex of the left lung and pleural space with the manubrium in the midline. However, the lower border is set to the superior border of the aortic arch. These color-coded CT images help reinforce station 2 lymph nodes. Again, realize the manubrium is in the picture. So we're below the top of the manubrium, and we're above the superior aspect of the aortic arch, and we're above where the left innominate vein, the caudal margin of it, crosses over the trachea, basically the left innominate vein SVC confluence. And if you're to take an imaginary dotted line from the posterior aspect of the left subclavian artery to the right innominate vein, that would separate 2R and 2L from additional lymph nodes, which we'll talk about in the future. And then posterior, take an imaginary horizontal line behind the trachea, and everything above that would be considered 2R. The next station I will discuss is station 4 lymph nodes, also known as lower paratracheal lymph nodes. Again, station 4 is further subdivided into 4R and 4L, with right versus left distinction set to the left lateral border of the trachea, the same as for station 2 lymph nodes. Station 4 lymph nodes take off where level 2 finished. So basically, the upper border for station 4R is the intersection of the left innominate vein with the trachea, and the lower border, this is an important definition on here, is the lower border of the azygous vein. As I said before, the left lateral border is the left lateral border of the trachea. Now, for station 4L lymph nodes, the upper border is the superior aspect of the aortic arch, and the lower border is the upper rim of the main pulmonary artery. So let's look at some CT images to help reinforce this definition. As you can see in the image on the top left, we're at the left innominate vein / SVC confluence, and we're at the level of the aortic arch. So everything below this is now considered 4R and 4L. Again, we're constrained by this dotted line that's posterior to the trachea, which would be considered 3P, and we'll go over that in the future. And on the image to the right, you can see that there's the azygous arch, or the azygous SVC confluence, so we're still considered a 4R lymph node and a 4L lymph node because we're above the upper rim of the left main pulmonary artery. The next station is station 3 lymph nodes, further divided into 3A and 3P. 3A, also known as prevascular lymph nodes, have their upper border set to the apex of the chest, lower border set to the level of the carina, anterior border set to the posterior aspect of the sternum, and its posterior aspect on the right set to the anterior border of the SVC, and on the left common carotid artery. So let's take a look at some axial images. Again, station 3A lymph nodes extend from the apex of the chest to the level of the carina. Some may consider the apex of the chest to be the upper level of the manubrium. They lie anterior to the SVC and anterior to an imaginary line that extends from the left subclavian artery to to the right innominate vein. 3P lymph nodes, also known as retrotracheal lymph nodes, the upper border is set to the apex of the chest, and the lower border is set to the level of the carina. The anterior border is set to the posterior aspect of the trachea. Again, that dotted imaginary line behind the trachea distinguishes 3P from 2 and station 4 lymph nodes. Stations 5 and station 6. Station 5 corresponds to AP window lymph nodes, station 6 paraortic lymph nodes. AP window lymph nodes, also known as subaortic lymph nodes, are defined as lymph nodes lateral to the ligamentum arteriosum, extending from the lower border of the arch superiorly to the upper rim of the left main pulmonary artery inferiorly. Station 6, also known as paraortic lymph nodes, are lymph nodes anterior and lateral to the ascending aorta and aortic arch, with the upper border being aligned tangential to the upper border of the aortic arch, and the lower border being the lower border of the aortic arch. Again, these color-coded CT images help reinforce stations 5 and station 6. Please note, on the image in the bottom right, we have the ligamentum arteriosum separating station 5 and station 4. Station 4L here is usually often confused for AP window lymph node. Subcarinal lymph, very controversial lymph node station here. Also known as as I said, station 7 is subcarinal lymph nodes. So in this new lymph node map, the upper border of station 7 is considered to be the upper border of the carina, and on the right is set to be the lower border of the bronchus intermedius, and on the left, the upper border of the left lower lobe bronchus. Again, color-coded CT images to help reinforce the definition. Notice that the image on the image B, which is the lowermost image, is at the lowermost aspect of what we would call a subcarinal lymph node, because we see the bronchus intermedius on the right, and at the same level you see the left lower lobe bronchus. Stations 8 and 9 correspond to paraesophageal and pulmonary ligament lymph nodes. Paraesophageal lymph nodes are lymph nodes lying adjacent to the esophagus, and they start after the subcarinal lymph nodes. So therefore, the upper border on the right is the lower border of the bronchus intermedius, and on the left, the upper border of the left lower lobe bronchus. And then its inferiormost extent is the diaphragm. Pulmonary ligament lymph nodes. These are lymph nodes lying within the pulmonary ligament, with the upper border set to the inferior pulmonary vein and the lower border set to the diaphragm. And on the image on the top right is just an image of the pulmonary ligament. And you could trace it back, and any lymph nodes along there would be considered pulmonary ligament lymph nodes. Again, these color-coded CT images help reinforce stations 8 and 9. So the next few stations we will discuss are the pulmonary lymph nodes or parabronchial lymph nodes, basically stations 10 through 14, station 10 hilar, 11 interlobar, 12 lobar, 13 segmental, and 14 subsegmental. Controversial station here are station 10, which would be considered an N1 lymph node if the tumor is on the same side. So let's pay attention to this definition. So these include lymph nodes immediately adjacent to the main stem bronchus, with the upper border set to the lower rim of the azygos vein, and the images provided in the paper that gave the definition show that this to be basically where the azygos vein joins the SVC. The lower border is considered the interlobar region, which we'll discuss in the next couple of slides. And however, station 10, the upper rim is the main pulmonary artery on the left, and the lower border again is the interlobar region. Interlobar regions are explanatory lymph nodes between the origin of the lobar bronchi, and therefore on the right we have 2, and on the left we have 1. So on the right, they're further divided into 11S and 11I. So 11S is between the upper border of between the upper lobe bronchus and the bronchus intermedius, and 11I is between the middle and lower lobe bronchi on the right. Again, color-coded CT images help reinforce station 10 and 11 lymph nodes. Lobar, segmental, and subsegmental are self-explanatory. Those lymph nodes lying adjacent to the lobar, segmental, and subsegmental lymph nodes. So just, I do this for my residents, just some miscellaneous lymph nodes which weren't included in the lymph node map that we should be aware of in lung cancer and any other types of cancer or just any patient. And these include the diaphragmatic lymph nodes, which are further subdivided into 3 groups, the anterior, middle, and posterior. The anterior are known as the cardiophrenic lymph nodes, located anterior to the pericardium, posterior to the xiphoid process, and in the right and left cardiophrenic fat pads. And we have the middle diaphragmatic lymph nodes, also known as juxtaphrenic or lateral diaphragmatic lymph nodes, located lateral to the intrathoracic end of the IVC. And then the posterior retrocrural, located behind the diaphragmatic crura and anterior to the spine. Often you see these lymph nodes enlarge in patients who have liver disease, as these lymph nodes drain the liver. And these lymph nodes also communicate with lymph nodes in the chest including the paraesophageal and internal mammary lymph nodes. So if you see those lymph nodes enlarged in a patient with cirrhosis, you can surmise that it's related to liver disease. Additional lymph nodes include axillary lymph node groups, further divided into 4 groups, which we don't need to go into. We have the internal mammary lymph nodes, which are located at the anterior ends of the intercostal spaces along the internal mammary vessels. And we have the posterior intercostal lymph nodes located near the heads and necks of the posterior ribs. So when I approach a chest CT, when I look at the lymph node section part of my template, I basically address mediastinal lymph nodes, pulmonary lymph nodes, which are 10 through 14, the partially imaged lower cervical lymph nodes, and then the chest wall lymph nodes as separate groups. So let's talk about size criteria and common pitfalls. Basically, we've been taught that any lymph node measuring 10 millimeter or more in short axis is considered significant in size and suspicious for metastatic disease, although the predictive accuracy of this criterion is limited. And we all know of cases where lymph nodes are greater than 10 are not metastatic, and those that are less than 10 are not metastatic, and sometimes images are not completely easy to measure. And remember, this is there, if you think of a lymph node in 3D, getting a true short axis is kind of hard. So most importantly, if you have a comparison study, is to evaluate for new or enlarging lymph nodes, even though the lymph node may be less than 10 millimeter in short axis, for evaluating metastatic disease. Common pitfalls include pericardial recesses and sinuses, often mistaken for lymph nodes. These include the superior aortic recess, which is often, if it has a high writing variant on the image on the top left, can be confused for a paratracheal. Sometimes they can be called prevascular. Sometimes they can be called periaortic. Again, here is the superior aortic recess, sometimes confused for an AP window lymph node, sometimes paratracheal, prevascular. We have the oblique sinus on the left, often confused for subcarinal, which again would make it an N2 lymph node. And we have the pulmonary venous recess, which sometimes is confused for a pulmonary ligament or pulmonary vein lymph node. And now for our post-presentation question. The shaded region corresponds to which lymph node station? A, precarinal, B, left upper paratracheal, C, left lower paratracheal, and D, AP window. How you label this lymph node is important because it depends on if this was needed to be sampled, and let's see what everyone gets. Correct, left lower paratracheal. I've often seen this labeled as an AP window lymph node. And if this was if this is the lymph node that needs to be sampled and you call it an AP window lymph node, you basically have told the surgeon that he needs to do either a Chamberlain procedure or a VATS to access this lymph node. However, if this is just a left lower paratracheal lymph node, you could do an endobronchial ultrasound or an endoscopic ultrasound to sample this lymph node. So that's really important to know your lymph node stations so that you and your surgeons and interventional bronchoscopists are on the same page.